Mazloomdoost. We generally refer to him as Dr. Danesh. We met Dr. Danesh a number of months or years ago in discussing effective ways to treat pain and providers who would be responsible in doing that and not just fill people up with opioids and tell them if they still hurt that the answer to it's more opioids. He has and works in a multidisciplinary pain clinic that he is in charge of and that has produced as better results for things that we have sent than we have seen anywhere else. He has an incredible intellect and a level of responsibility to try and not only get folks to be pain-free, but also help them do it in a way where they can, or not be pain-free, but figure out a way to manage their pain and accept the reality that they are going to have to work at managing their pain, but they can become productive people once again. So he has an incredible amount of knowledge to pour out to us today. And Dr. Danesh, appreciate you being here.
Thank you. Thanks for those kind words. Thank you to everyone for being here. If you guys were here for the previous conference that was done, there is some similarity to that. So, but my wife's a psychologist, and she says that it takes people at least 6 or 7 repetitions for something to sink in. So hopefully that's not the case. What I'm going to talk about is multidisciplinary pain clinics and how at one point they were something of gaining popularity, and then all of a sudden things fell off the map, and the impact of that on the management of pain. So there's this common statistic that says 1 out of 3 Americans deals with chronic pain. And I'll be honest, I hate that statistic because it conveys the notion of a disease state that really is far from reality. Nonetheless, a third of the population has chronic pain. And in spite of the expense in healthcare, with over $3 trillion expended each year, we're still not really getting ahead of this problem. And this is essentially why. So if somebody goes to their physician, the first thing that, with pain, the first thing that happens is conservative care. What does conservative care typically mean? It's usually anti-inflammatories, maybe a steroid dose pack. More often than ought to be the case, opioids are initiated. And then they might go to physical therapy without really truly understanding what is causing the pain and what's going on. Now, a large number of these people will get better, but it's more a reflection of just the nature of your body healing. But for those who don't, the next step is often surgery. And surgery will impose anatomic changes. There's structural instability that's developed after surgery, fiber scarring, and loss of elasticity. After all, your body is biology, and it's constantly evolving, constantly growing and changing. But once you introduce a surgical event, you've now introduced a non-organic part of the body, which is not going to evolve with you, and it's likely to cause other problems. And then finally, as a last step, patients will get sent to pain management. These are the patients that often have failed everything else before they get to a pain specialist. And the expectation for most patients and doctors is that this is a patient who's lost hope, and now they're just going to be in this revolving door of opioid management with the barrage of compliance monitoring, chronic anti-inflammatories, the occasional steroid injection, and essentially just sit on this patient for the rest of their life. So essentially this model is really nothing more than a palliative model. We haven't really done anything to understand the origin of pain, diagnose it, or treat it. And if you look across the healthcare industry, really, when we come to managing pain, it's one or the other, either palliation or surgery. And our status quo is somewhere in the middle. And I find this to be problematic. It's a very unifocal approach that is almost geared to failure. All of our diagnostic workup is based on surgical outcomes. When you look at the variety of things that radiologists will comment on in the radiology, it all has some surgical impact. So the outcome of that is if you're looking for surgery, you're going to get surgery. And if you're looking for the diagnosis, it's not going to be in the radiology. It's going to be in the history, the physical, the understanding of how the physiology of kinetics work, how the body moves, and what happens when it starts to break down. I'll give you an example. I think low back pain is one of the most common causes of pain that people seek help for. And when you look across the spectrum of normal individuals, if you take 60, the demographic above the age of 60, 36% will have disc herniation, 21% spinal stenosis, and greater than 90% of them will have degenerated discs, or what's termed as degenerated disc disease, which I find to be a little bit of a joke, because if you're going to say degenerative discs is a disease, then we should call wrinkles and gray hair a disease as well. Aging is not a disease. In spite of that, we've seen this dramatic movement in this direction, in the wrong direction. Dr. Deo is a great researcher. He works a lot in Cochrane and review studies that look for best outcomes or efficacy of treatment. And he wrote a book on this. It was such a compelling topic that he actually consolidated it into a book called Watch Your Back. In it, between the decade of 1990s to 2000, we saw this threefold increase in the number of MRIs being conducted, 200% or double increase in the number of surgeries, with a tremendous amount of money being spent on it. Each year, we spend about $86 billion on backs, which is 9% of the total healthcare expenditure. And when it comes down to surgical things, the spinal hardware alone costs nearly $4 million, and the hospital fees to implant that hardware costs about tenfold that. So we're looking at around $40 billion in cost. And what do we get for those surgical interventions? 70% of those people never return to work. And when you add in other variables like legal representation, the duration of time before they seek treatment, depression or opioids, you get much greater losses of people coming to work. Depression alone, if somebody has comorbid depression, you are almost guaranteed not to get that person back to work. And there are other problems with surgery, because most often patients who undergo surgery will receive opioids, and the outcome of that has been a pretty dramatic growth in the population that are chronically dependent on opioids. There's this great study that came out of University of Michigan where they looked at a wide spectrum of surgeries, from minimally invasive things like a hernia repair or varicose vein removal, through the more complex things like bariatric surgery or colectomy. And regardless of type of surgery, they found across the board after 6 months, people were still taking their opioids, approximately 6% of them. There's no correlation between the invasiveness or the pain outcome of a surgical case. This is simply the effect of opioids. In fact, this statistic is so dramatic that it makes it the number one complication from surgery of all causes. We framed pain around opioids. We talk about pain management as if this is the panacea, this is the treatment that works. And the reality is it doesn't. It's been this very systematic process of trying to convey the notion that opioids are the way to go. And this was done through a methodical process that is now documented, that pharmaceutical industry took on. They looked at studies and they really misrepresented them. Most of the studies coming out that said opioids are safe, that they're effective, were always drawn from very small conclusions out of a study. They downplayed the harms, they upsold the benefits. They recruited key opinion leaders, physicians in the community who were trusted, and paid them handsomely to talk about the benefits of opioids. They recruited advocacy groups, some of which were completely propped up by the pharmaceutical funding. American Pain Foundation had 95% of their funding from pharmaceuticals. And they leveraged these people who have pain, which I view as a very vulnerable population. If you've ever experienced pain, it breeds this sense of desperation to get out of it. And they leveraged these people for financial gains. They stigmatized and diverted people who were trying to say, hey, we got to slow this train down, and portrayed them as heartless. And on the flip side, on the patient side, the patients who eventually do become compliance concerns are painted as addicts, and we shun those people. As a result of this, the pharmaceutical industry became a multi-billion-dollar industry around opioids. We talked about hardware, the spinal hardware costing $4 billion a year. Well, pharmaceuticals are generating approximately $10 billion a year at this point. And it's been a very steady increase, and that's why you see this push towards a variety of different types of opioids, be it abuse-deterrent formulations, long-acting formulations, anything that they can get a patent around. Well, the conversation has constantly been around safety. How do we address the opioid problem with greater safety? But when we focus on this as the conversation, talking about opioid risk tools and urine testing and patients not becoming addicted if they take it as prescribed or trying to stay ahead of their pain by taking pain medications, all of this conversation bypasses a very important point, which is efficacy. Is it even worth having the conversation around safety if these medications are deemed to not be effective? As a result of the pharmaceutical influence, we've seen this growth in opioid use, and the question then becomes is, have we seen an improvement in pain outcomes? Well, when you look at every demographic, every age group, you can see that every population is complaining about greater levels of pain. Well, how is that possible? We've introduced this treatment by large margins, and we're seeing worsening outcomes or worsening pain complaints. If you look in the Workman's compensation studies, there's a lot of evidence as to why this is the case. The problem is that once you introduce opioids to an injury, you're increasing the cost of care and increasing disability. And you can ask why. We'll get to that in a moment. Across the U.S., when you look at rates of opioid use, they correlate very nicely with complications such as addiction, which is not, or overdose, which is not the only complication. And particularly when you look at the Appalachian region, you see really high rates of opioid prescribing and use. In fact, Kentucky ranks among the 5th highest. These are a little bit variable each year. And between the 3rd and the 5th highest in prescribing. They rank 5th highest in illicit opioid use and between 3 and 5 for prescribing rates. And when you look at the disability trends, you can see that Kentucky and West Virginia rank 1 and 2 for disability rates in the country. They looked at a period of time of 1 decade, looking at a workman's comp population at the beginning of the millennium and then towards the end of that first decade. And at the beginning, 40% of patients were prescribed an opioid for their injury, but even when they were prescribed an opioid, it was of low potency or low dose, only 10 milligrams. By year 7, 80% of that population was prescribed an opioid, and they were prescribed much greater doses, essentially a dose of medication to where they're chronically medicated every single day. Well, this had an impact on the duration of claims. We saw an increase in the number of days in duration of claim. And short-acting versus long-acting opioids also showed a difference, with long-acting being longer duration. The onset of opioids has an impact. If it's initiated early on in an injury, the probability of that injury becoming more chronic of having surgery, of staying on opioids is all increased. The potency has an impact, as I mentioned earlier, that stronger opioids are more disabling than weaker opioids, and overall the cost of care goes up once opioids are introduced into the equation. The reason for that is very simple. What most people don't understand, and I'm going to give you a trade secret here that even physicians don't really quite understand. What do opioids do to the body? You can think of the body as a rubber band. If you pull it down in one direction, it's going to recoil in the opposite direction. So if you dose somebody with an opioid, yes, they get an analgesic effect for the duration of action of that medication, but what happens when that medication starts to wear off? Well, you get a rebound hypersensitivity to pain. This doesn't mean necessarily that your pain increases. It just means your threshold for pain is reduced. And this is very common sense. If you take a bite of a candy bar and then you bite into an apple, that apple is not very sweet. If you stand outside in the sun and then walk into a dark room, it takes a while for your eyes to adjust to that light difference. These are things that are kind of common sense, but somehow have been completely masked and overlooked with this push towards managing pain and opioids being the solution. Well, managing acute pain kind of makes sense using opioids, and albeit I would even argue that this is arguable, that opioids are the best way to treat acute pain. But for the sake of argument, if somebody has an acute pain, you know that there's a peak, and then it's going to reduce. And if you can time the hypersensitivity with that reduction in pain, there really isn't a substantial difference. They can get the analgesic effect without that rebound hypersensitivity. But let's say we're talking about chronic pain. Well, when a patient takes their medication first thing in the morning, they get some analgesia, but then they get a rebound. And so that's their cue. This is the time I need to take more medicine because my pain is starting to get bad again. And so they haven't allowed enough time to elapse for that rebound hypersensitivity to normalize. And so they're stacking the effects of that hypersensitivity on the previous dose. And over time, when you're chronically medicating somebody, you're essentially making them more and more sensitive to pain. The problem is that when you introduce opioids to a pain issue, the line between pain and opioid dependency becomes very blurry. It's very difficult to differentiate whether this is an organic etiology of pain or a physiologic source of pain, or if you're dealing with, yes, there is a presence of pain, but the magnitude of perception of pain is amplified because that patient is constantly in a hyperalgesic state. That the hyperalgesia from an opioid outlasts the period of analgesia. So essentially, they get a few hours of benefit throughout their day, but they live at a higher intensity of pain the rest of the time. Pain is very complex. It's the equivalent of a check engine light. You don't get a check engine light on your car and know exactly what's going on. It takes some digging to figure that out. There are a lot of organs and tissues that signal pain, and when there's an abnormality to any one of these, there can be a pain signal generated. But it goes beyond that. It also goes into the psychology of the individual, how they cope with pain, how they cope with adversity to begin with, their behaviors around any challenge, their constitution and their physical ability to heal, how their body responds to an injury, and how well it can recover from that injury. And the reality is, most of us do a good job of recovering from injury. 90% of low back pain resolves within 3 to 6 months. So that primary care physician who starts that patient on steroids or anti-inflammatories or does all this different workup, they're going to be right about 90% of the time, but it's not because of what they're doing. It's just the nature of healing and the biology of being. And pain specialists are not a one-size-fits-all solution. We talk about, well, this patient just needs an epidural. Epidural is not the only thing out there. It's one tool, and it's a very blunt tool, if that. There are other treatments that interventional management ought to be looking at and using their skills to understand and diagnose pain. We call the guys who do epidurals or one-size-fits-all solution for everyone needle jockeys. The problem is this whole approach, everything that I've talked about, ignores this one main important slide. The whole healing cycle, how our body recovers from injury, what it's requiring in order to recover or heal damaged tissue. Essentially, whenever you get an injury, the initial stage is an inflammatory stage, which is a protective stage. It's the process by which all the cells migrate to the area of injury, and there's swelling so that your body knows it needs to slow down in utilization of this area. All those cells will start to proliferate, regenerate new tissue, and become healthy new tissue. But then it requires that patient to go through a rehabilitation process, through physical therapy, through training, in order to normalize that tissue into healthy, normal, functioning organs. I'll give you an example. If somebody comes into the ER with a broken leg, you don't know that person is coming in with a broken leg. You just see them as having ankle pain. And then we make the assumption that that this person is just an ankle pain. Normally what would happen is you get an x-ray and you'd see the damage and you'd put that person in a cast. But if you just make the assumption that every person coming into the ER with ankle pain has an ankle sprain, because that's just what's more common, and you treat every single one of them with some pain pills and tell them to walk it off, it's common sense what's going to happen. That person's not going to have a functioning leg. But this is exactly what we're doing for a wide variety of pain issues. We're making assumptions based on blunt instruments like just an imaging tool, not really getting an understanding of what's going on physiologically with that patient's injury, and then making the assumption that we know what's wrong. And then we throw them a whole bunch of treatment modalities that may be completely off base. Surgery is not the worst thing in the world. It has its role, but if we assume that every degenerative disc, or essentially what I call degenerative wrinkle disease, is a surgical necessity, we are essentially disabling our population. The focus is figuring out how we can better utilize this and what we're doing right now that's hindering this treatment, this recovery process. Anti-inflammatories, for instance, can be helpful in reducing the sensitivity or reducing the pain, but they're going to inhibit this repair process. Now, more often than not, our body is resilient enough to overcome that and still manages to push through into a proliferative and regenerative stage, but sometimes it doesn't. Opioids completely obliterate the notion of that existence of that injury, and so that person keeps re-injuring that and building more and more scar tissue that makes it harder and harder for it to heal. Surgery bypasses the system. It introduces in non-organic or artificial environment into an organic responsive environment. Your body doesn't know how to respond to an inorganic source, and we often see a foreign body forms, a cyst forms around the body to kind of segregate that off from the rest of the body. Your body communicates within itself and figures out things that you and I are not smart enough to do. And surgery just kind of bypasses that. And then finally, steroid injections, similar to anti-inflammatory. The doses of steroids that we're injecting into people are massive, astronomical doses of steroids. Typically, if I'm putting a steroid into somebody, I'll do 1/20th or 1/40th the dose that's typically prescribed or that I was trained in, and I'm getting better outcomes than those mega doses. So essentially, it's iatrogenic hopelessness. We have bred a culture of hopelessness when it comes to pain. You're not allowed into this treatment of pain unless you've completely abandoned all hope. And I call this the broken beyond repair syndrome. When a patient has seen the surgeon, has been to the physical therapist, and then they finally, as a last-ditch effort, come to me, they have been told by multiple people, there's nothing we can do about this. This is chronic pain, and you need to go to a pain management specialist so they can just get you on drugs. That's a very self-defeating notion. It completely obliterates the notion that the body can heal. It completely demoralizes people that they can cope with this, they can live with this, they can overcome this if they treat it properly. The standards of care right now in medicine, I equate it to the Model T and multidisciplinary care being KIT. It's the It's the intelligent, kind of witty antidote to conventional medicine. Essentially, conventional medicine is compartmentalized. You see a surgeon who doesn't really communicate with the radiologist who reads the report, or the primary care or physical therapist who's examined the patient and really put their hands on that patient to get an understanding of what physiologic changes are happening in the kinetic chain. It's very simple. It's problem, solution, without a lot of thought in between. It's managed care oriented, meaning that the decision makers are looking at the entirety of the population and lumping a whole bunch of people into the same category, treating every low back pain the same. It's passive. Patients are typically pursued or directed toward an appeasement avenue, meaning like physical therapy. Their focus is trying to get the patient feeling better and encourage them to come back with a little bit of physical therapy that is straining the body or causing pain, the necessary process to evolve that injury. It's inexpensive up front because you're looking at the quickest and cheapest way of getting that person some perceived perception of relief. But in the long run, ignoring the problem, medicating it, is causing long-term problems that we're seeing now. The contrast to that is a multidisciplinary approach in which individuals in this arena are highly skilled. They're very collaborative. They learn from each other. I will be the first to admit that I don't know everything about the kinetic chain. I don't know everything about the physiology of our muscles and joints. That I learn a lot when I speak with my physical therapy colleagues. I don't know the best way of approaching every patient's situation or conflict. And so I get a lot of help from my psychology and psychiatry colleagues. It's one-on-one coordination, looking at the individual patient, figuring out what that specific person's needs are, really getting a better sense of the diagnosis, and then working up a treatment, not pushing everybody into a one-size-fits-all solution. It's active. It requires participation from the patient, and this means that it's not always comfortable, it's not always pleasant, and sometimes, yes, it is going to worsen the pain before it gets better. It can be expensive up front because amassing all of these people working collaboratively together is not a cheap way of doing things, but in the long run, it's a lot cheaper if we're able to actually get people better and keep them well enough to where they're not constantly dependent on the healthcare system to stay afloat, which is exactly what we're doing right now. So multidisciplinary pain, it takes into, it takes multiple perspectives in mind. The biology of the body coming in, having an injury, the psychology of that person, how they cope with pain, how they cope with adversity, their environment. Are they going home to an environment which puts more stress on them? Are they out of the workforce right now and having financial difficulties? And their health literacy. How well do they understand what's going on in their body? What that pain is signaling and what it's trying to tell them? And that requires a physician to be involved, a psychologist, somebody involved with physical conditioning or physical therapy, and a health educator. All of these people need to be collaborative, and they all need to present a front that shows an advocacy for patients, for the patients. It needs to be a safe, trustworthy environment for that patient to be frank and honest. And the problem we have with workman's comp is that every patient is trying to prove that they need workman's comp. And so every incentive is to show themselves as being sick. What's going to happen if you tell yourself every day when you stand up, you look in the mirror and you say, boy, you look terrible? You're going to feel pretty lousy. And if you do that every single day for years on end, you are producing that broken beyond repair syndrome where people don't have any hope of self-improvement. So functional restoration's role is a harms reduction approach. We do see a lot of patients who've been down the broken road before, and we're trying to re-educate them and undo a lot of misunderstanding or miseducation. So at first, it's primarily a harms reduction to reduce their opioids, to reduce the polypharmacy. I mean, how many patients do we see in chronic pain who have a list of medications that you think, I mean, that alone induces that broken beyond repair syndrome. To reduce the need for surgery or reduce the need for frivolous or unnecessary surgery, and overall reduce long-term costs. And then we want to focus on optimizing outcomes, looking at how do we increase function and how do we improve this person's ability to cope with pain. Can we get them back to work? If not the work that they were doing, then some kind of employment. I think taking people out of the workforce and giving them a disability is one of the most demoralizing things you can do to somebody, because everybody needs a sense of purpose. And if you have nothing else to focus on but your pain, your focus, your sense of purpose is surviving that pain. It's not thriving in life. It's providing goal orientation, figuring out what are some baby steps that this person can take to get back into the normal swing of life. And then aligning their motives and accountability, because we know that patients who've been in the workman's comp system lose that sense of motive, lose that sense of accountability. They throw their hands up and say, here are my problems, you fix it, I'll be back next month to get my meds. And we need to engage them to get that sense of accountability back. Essentially, the entire process is how do we minimize the harm that medicine is causing on people, which it is. And there's a lot of good evidence for multidisciplinary pain practices. In fact, back in the 90s and early 2000s, there was a strong movement towards multidisciplinary pain. Prospective studies showed 8-fold fewer missed work days, 2 times greater recovery rates. Long-term outcomes were much better. People who had gone to a multidisciplinary pain program were, if not better than their peers, then at least on par with patients who had not. And greater than 50% of them had gone back to work. Those who were unemployed reported that it was not because of pain that they were unemployed, it was for other reasons. In Cochrane review studies, they looked at a multitude of randomized controlled trials on multidisciplinary pain, and they showed them to be superior in pain control, disability rates, return to work, and the number of sick days once they do return to work. And yet, in spite of all this, we see this decline in the number of multidisciplinary pain clinics. As early as 1998, there were over 200 accredited multidisciplinary pain clinics. And by 2017, there are only 36 outside of Texas. Texas, for some reason, has held on to this notion of multidisciplinary pain. But we see this progressive decline. Why is that? It's because there is a moral hazard when it comes to any decision making. And moral hazard means that the person making the decision is immune from the consequences of those decisions. And with pain being a relative symptom of many conditions, there are many things that you can introduce to that to give a perspective of, yes, we're reducing the symptom of pain without really giving objective evidence of improving the condition causing it. And when you look at the patients, the people involved in the patient's care, who are the people that actually have the incentive to get people on the track for recovery as opposed to just status quo? If we look at all of these individuals involved in that patient's care, the primary care physician is inundated with patients and patient problems. I mean, we have a sicker nation than we have ever in history. And we have fewer clinicians able to see those. So when they see a pain patient, if somebody says, here's a problem, here's the solution, they're going to jump on it. The pain specialist across the country, I criticize my colleagues because I feel like pain management has become an annuity. It's become get the patient in, start them on a pain medication, and then have them come back on a monthly basis to get their medication, to do their toxicology, and then we'll throw in a few epidural steroid injections just for palliation. Surgeons are surgeons. They're going to operate. They don't have any incentive to say, you know what, let's try some conservative management, or let's try to get you feeling better about this. If they see a problem, they're going to operate on it. what I call the hardware store is essentially the medical device manufacturers that produce all the products that go into people's bodies. Hospitals, they would love to see more patients coming in and collecting the facility fees. They love pain specialists because the volume that pain specialists do is a tremendous cash cow. The pharmaceutical industry we covered earlier, they have every incentive to dissuade patients from getting better. And insurance companies are looking at the bottom line. They want to look to see what is going to be the cheapest approach. And in reality, the cheapest way to address a pain issue in the short run is to get them on a pain medication and suppress the symptoms. But it's doing nothing for that patient. So what I advocate for is a dramatic paradigm shift, because we've got a palliative perspective when it comes to pain management. And really what we ought to be looking at is a regenerative model of health. Pain is not the problem. Pain is just simply a messenger. And in order to understand what that messenger is saying, we have to focus more on the message being said. We have to look for the disease or the condition that is causing the signal of pain. So here's what I see in the future. This is the model that I'm trying to make standard of care, where you have a biomedical perspective, and it's more geared towards a regenerative model of health rather than a palliative model of health. But then you have to get recruitment from other disciplines, psychology and kinetic movements. This is the center of this is what I call the primary care for what hurts. If it hurts, this is the first place people should go to, not to the primary care, maybe even not to the ER, but really come here so we can isolate the problem early and intervene. When you look at pain in general, it has multiple components to it, and it's these multiple components that make it so difficult to understand, because every tissue produces a signal that your nervous system picks up. Typically, it's a normal signal. It's something that says, hey, I'm okay. And when you get that A-OK signal, the brain thinks everything is peachy. But once you have a tissue injury, that signal is going to change. That the frequency of that signal changes, and the nerves that transmit that signal to the brain also start to change. And then the brain that sees that signal starts to see changes as well. So I equate this to a very simple analogy that's helped my patients understand what we're doing. And that's that pain signals are like radio stations. And if you love country, but it's on classical, that classical station is going to be obnoxious. But if the volume is turned down, that classical station is not really heard. And your nervous system ramps up or ramps down that signal. It amplifies or demotes that signal. And then your brain decides, do I like country, or really do I like classical music? And it's the brain that decides if this is an irritating signal or a tolerable or even a pleasant signal. Every pain issue has an impact on all three of these components. So understanding or dissecting pain means isolating each component and seeing what happens to the pain signal or perception of pain. And so this is the model that I use in my practice. I call it the HEAL model, where our first step is to hear the pain, really hear that radio station, try to tune out all the other radio stations to understand what that radio station is putting out. Then we try to engage with the patient and figure out what is the functional limitation that's imposed by these pain signals. What is your body trying to tell you not to do that you want to do? And then the second stage we move into is the treatment stage, where we work to alleviate the symptoms, reduce the pain, but also figure out how we can leverage the body to heal this issue. And it really is this two-step process. And more often than not, in our current healthcare model, we ignore stage one and we jump to stage two. We make assumptions based on x-ray, based on probabilities, and we don't go into the depth of understanding what's going on. So how do we, I'm going to start with just the diagnostic stage. How do we figure out what's going on? It's getting better attuned to the body kinetics, how the body functions and how it moves, what it uses as pivot points and what it uses as support structures. Because every pain issue has some impact of this. Whether it's maladaptive movements, if you sprain your ankle, you're going to limp. That's how you get around. And if you limp long enough, that becomes your normal gait. It becomes the movements that your body produces without you thinking about it. It's muscle memory. But on top of that, there's neurologic changes. It's the way that your body responds to signals. The spinal cord will actually wind up its sensitivity to pain when it sees a pain stimulus. If, for instance, I came up to one of you guys and started poking you in the arm, it wouldn't be terrible. You wouldn't hate me for it. But if I stood there the rest of this week and kept poking you in the arm, at some point it'll get so sensitive where even your clothes touching it will hurt. And that's because of the wind-up neurologic effect of the spinal cord. Movement instability is what's the precursor to a lot of degenerative processes like arthritis. Understanding this is really important because I see a ton of patients who get vesical lubricant or rooster comb injections into their knees, and they come back every 6 months to get a refill of that. This isn't like your car. You're not having to refill the lubricant in your knee in order to keep functioning. It's because something else is blocking that joint from healing. And typically that's an instability. It's some ligament laxity that's causing that joint to move in a direction it's not supposed to. We talk about sciatica and neurologic problems as there's one condition that does all of it, and it's not the case. Sciatica is not a condition, it's a symptom. It's a pain down the leg, but there are many conditions that can cause that. And if every leg pain distribution of back pain is deemed as a discogenic neural compression of a nerve, then you've got a hammer and everything's going to look like a nail. We've got a disc fetish in this country where we focus so much on the disc as the cause of all pain that we ignore all the other things that can be causing problems. And there's a lot of things that can cause those problems. All of these conditions are non-neural compressive conditions, but they all mimic that neural compression symptom. For instance, this pink one is piriformis syndrome. And I see a lot of patients who have had operations, have been even fused in their spine with consistent residual pain. And we find out that it's just a very simple piriformis strain that just warranted some physical therapy. Soft tissue components of pain are more often than not overlooked. And when it comes to low back pain, soft tissue is really the precursor to a lot of other problems. The sacroiliac joint, we always call it sacroiliac arthritis or arthropathy. It's typically not an arthritic issue. It's more often than not a ligamentous issue. But if it's ignored long enough, that's when you start to get radiologic changes that signal arthritic changes in that joint. The spine is essentially a suspension bridge, and the kinetic tension lines are distributed through the myofascial or the soft tissue, the ligamentous structures. And more often than not, if you get a small injury to one of these ligaments, it becomes a domino effect because it changes the whole kinetic chain. That's kind of the focal point for all movement, be it upper limb or lower limb. Everything, all those pressure vectors intersect and cross at that low part of the back. And that's why we see so much low back pain. So once we dissect the pain out and we figure out what's wrong, then we want to start the treatment phase. And this means that we do want to get the patient out of pain quickly and try to alleviate their sensitivity and their pain. But we also want to maximize the body's ability to heal. Every single one of these points has another lecture I could give on it, but I'm going to focus more on this last one just simply because there's very little understanding of it. If we go back to the healing cascade, the intent is to try to augment this or amplify this or reinitiate this when you see a chronic injury. Essentially, your body has two processes, one that breaks things down and one that builds it up. And we want to figure out how we can augment the part that builds things up. And that's essentially what regenerative pain is. Because as we age, one of the things that happens is that the cells that replicate, or we call them mesenchymal stem cells, or stem cells that are out in the periphery of the body, you get fewer and fewer of them. As they replicate less often. So when you get an injury when you're a kid, it heals within a few days. When you get an injury as an adult, it can last longer because you can't amass the critical mass needed to repair that process. And that's where regenerative medicine comes in. So you guys hear about prolotherapy, PRP, stem cell injections, and it sounds really sexy, and it's new, it's exciting, but it's really what your body does every day. It's the process of healing. And everything that we're doing within regenerative medicine is just simply to try to augment that process. There's a wide variety of conditions that this treats. I won't go into great detail over this just because I'm starting to run short on time, and I want to give time for questions. But sclerotic issues, things like frozen shoulder, plantar fasciitis, fascial release problems like carpal tunnel, cubital tunnel, all of these are sclerotic issues that can be addressed non-surgically with regenerative techniques. Ligament laxity, as I described earlier, with knee arthritis or knee pain, for instance, or even low back pain. A lot of low back pain issues is originating from ligament laxity and the changes in the kinetic chain as a result of that. Tendinitis develops into tendinosis as a chronic condition. All of these, in fact, epicondylitis or tennis elbow, golfer's elbow, there are a few randomized control studies that look at regenerative techniques. And for tennis elbow and golfer's elbow, this is one of them that shows superiority of regenerative techniques over the conventional steroid dose. In fact, I would say if you ever get tennis elbow, hold off on that steroid injection because it typically will give you some relief, but it also weakens it, and with that being such a fragile tendon, it makes it worse. Bursitis, we always think of as an inflammatory pocket of fluid somewhere in the body. It's not often the case. It's actually more often a tendon or ligament issue that causes another tendon or ligament to run in a different way or work differently. And it can be easily treated with the regenerative process. Even fractures, we're able to amplify the body's ability to heal a fracture using a regenerative technique because when you break a bone, you're essentially doing a regenerative technique. You're bleeding into that injury, and that blood coagulates and becomes the nidus for the bone to grow into and heal. So that's the biomedical part of it, but we also have the psychological and the kinesthetic. And when we talk about the psychology of pain, we know that pain has a huge impact on your state of well-being or your sense of emotions. A lot of emotions evolve when you have pain that doesn't go away. And these two feed off of each other. I won't go into the neuroanatomic or neurophysiologic causes of this, but take my word for it that the part of your brain that deals with physical adversity like pain is the same part that deals with emotional adversity like emotional distress. And when you deplete the resources because everything's going to one, it's going to deplete the resources available for the other. So this is a natural evolution that we see in pain management. And the intent is to try to get the patient to go from symptom-focused and fixating on the symptoms that they have and start working towards how do we get them back to a more functional, goal-oriented perspective. If we look at the kinesthetic perspective, this is using exercise, nutrition, and a healthy lifestyle essentially as a prescription. How often does somebody go to the doctor with high blood pressure and they come out with a prescription for a pill rather than a prescription to exercise more? We say it as lip service that exercise is necessary, but in reality, it's having a healthy lifestyle is the foundation to healing. So we involve physical training, which is an extension of physical therapy. Physical therapy will focus on one area and get that stronger, but we want to then take that and make it into a lifestyle. So we look at functional movements that need to be retrained in the context of pain and figure out how we can get that person back into a healthy, sustainable lifestyle. Looking at functional movements that hold the body's integrity together as opposed to things that make you just look good. And it focuses on a multitude of different parts of movement, be it symmetry, balance, coordination, flexibility. All of these go into how a tissue recovers from an injury and how it heals. So I leave you with this slide, which is who's going to heal faster? The person who is kind of given up hope and is just looking for that base pleasure of eating their pizza, drinking their beer, and watching TV, or somebody who's actually taking care of themselves and trying to get healthier, or has the hope that they can heal. And if we do nothing other than try to reinstill hope in people as far as your body is a healing machine and it can get better, if we do nothing other than that, we're going to see a dramatic change in the opioid epidemic, in the disability problems we have. And healthcare needs to change its focus away from this disability perspective and look for rehabilitation.